Neuropathy, like many chronic pain conditions, has a variety of causes and a variety of often less than satisfactory treatments. Neuropathic pain, tonight, on call with the Prairie Doc. Health information based on science, built on trust for 21 seasons. Hello, I'm Dr. Deb Johnston, tonight's Prairie Doc. This season, we continue to bring our viewers trusted health information from doctors and health professionals within your own communities. Thank you for joining us again. Tonight, we are discussing neuropathic pain. Joining us in the South Dakota Public Broadcasting Studio in Rapid City are Dr. Cristina Sanders from Monument Health, Neurology and Rehabilitation, Dr. Tyler Ptacek from Rapid City Medical Center, and Dr. Matt Simmons from Monument Health, Neurology and Rehabilitation. Welcome, everyone. It's just great to have you. Dr. Sanders, tell us a little bit about your background and what drew you to physical medicine and rehabilitation.
Yeah, so my background is as a pediatric physiatrist, so I specialize in the treatment of mobility and functional impairments, especially in children. And really what drew me to physical medicine and rehabilitation is that it is about functional recovery. It's about returning mobility and independence to patients within their community and helping them succeed in doing better within their life, not just surrounding their diagnosis.
That's got to be so rewarding, especially with little people. And
it's pretty much awesome.
Yeah, seeing them grow up and achieve things nobody thought that they were capable of when it all began. Mm-hmm. Dr. Simmons, how about you? Tell us about your background.
Sure. So I'm a neurologist, and I specialize in adult neurological problems of the brain, the spinal cord, the nerves and muscles, really all of those disease processes. And I've just been fascinated by the nervous system from the get-go and had an early interest in that. And thankfully, in my career, neurology has changed from being primarily sort of a diagnostic specialty to more of a therapeutic specialty. And because there have been so many breakthroughs in treatment of neurologic disorders, that it has become a much more wide open and interesting field to provide treatment for so many disorders that historically were not easily treated. And so it's really been a gratifying career for me to be able to see all of the advances in the treatment of neurologic disorders.
That was an old joke when you and I were in medical school about the neurologist and stating the obvious and not a darn thing you can do about it. And wow, has the field changed. What an incredible explosion. So that has to be incredibly gratifying.
Exactly.
Yeah. Dr. Ptacek, tell us about your background.
So I grew up in a small town in Nebraska, and my dad was the town family practice doctor, and so I always knew I wanted to do something with medicine. And after going to medical school, I liked every bit of it, and I really stumbled into pain management. I feel like it's a very gratifying specialty because almost everybody deals with some pain in their life, and so to be able to offer a treatment solution or some guidance on how to deal with it is very gratifying for me.
That's another field that has changed remarkably in the time that we have been practicing medicine. The techniques and options that you have to offer people are just so different than they were 20 years ago.
Absolutely.
So,
probably half of the things that I currently do are new within the last 5 to 10 years.
That's amazing. Amazing technologic advancements. So our goal tonight was to talk about neuropathic pain, and particularly peripheral neuropathic pain. Dr. Simmons, tell us a little bit about the nervous system in general. We're talking about peripheral neuropathy. That means that there must be something that's not peripheral neuropathy. So give us kind of a brief overview of the nervous system.
Sure. So neurologists are often called upon to do diagnostic interpretation of neurologic disorders, and so we, as we mentioned earlier, we deal with the central nervous system, which is made up of the brain and the spinal cord, and then after that we think of the peripheral nervous system, which is the nerves, and then how the nerves connect to the muscles, and the nerves that connect to sensory functions as far as touch and pain and temperature and feeling vibration and feeling where we are in space. That's how the nervous system is basically divided, and our topic today is to talk about some pain issues that pertain to damage to the peripheral nervous system, and usually the peripheral nerves are the source of that. And so we're going to focus on that in our conversation today.
Cristina, what is peripheral neuropathy? What might somebody experience if they have peripheral neuropathy?
Yeah, so many patients that come into my clinic, either pediatric or adult, notice that they have a lack of sensation, or what we call an altered sensation. So they may experience numbness, burning, tingling, and interestingly enough, some of my patients will tell me that they experience kind of an altered sense of where their limbs are. I think my foot is on the floor. I don't feel steady when I walk. So you can not only have pain with peripheral neuropathy, but you can have other symptoms or self-reported events that can contribute in that way.
Can have a real impact on quality of life if you're always feeling that sensation. What kinds of things might cause peripheral neuropathy, Dan?
Well, that's a wide open question
That's a
because
big question.
many things cause it. It's important to realize that by far the most common cause is diabetes, around the world, and certainly in America. Diabetes is the most common cause of peripheral neuropathy. There are quite a number of other causes, and neurologists are often called upon to kind of sort out. So there could be toxicities, for example. Chemotherapy is a common cause. Many patients have received cancer treatment, and the medications that are used, the chemotherapy, commonly will cause neuropathy. As one example, there are other medications that can cause neuropathy. There are other toxins, in a sense. People that drink too much alcohol can have nerve damage. And we also see certain types of infections, certain types of immune disorders. There's a lot of hereditary neuropathy. That is, you've inherited a genetic abnormality that is going to predispose you to having neuropathy. So we often see like a family history of, oh yeah, my mom had it, or my and we see that. So there's really quite a variety of things that we might have to investigate. But thankfully, most of the diagnostic takes place by taking a careful history, understanding what the patient may have been exposed to, what their medical conditions are, doing a careful bedside examination. And with that basic information, we can usually identify the cause for the neuropathy. And then on top of that, if we're not sure, we will potentially do some additional tests to try and pin it down. So.
And I know that additional testing often falls in certainly the neurologist, but the physical medicine and rehabilitation doctors often do some of those specialized tests. Tell us a little bit about those, Chris.
Sure. I would say the most common diagnostic test that we use to assess peripheral neuropathy is a two-part test. And because we work in medicine, we abbreviate everything. So it is called a nerve conduction study, or an NCS, followed by an electromyograph, which is an EMG. So you may hear NCS, EMG, or a combination of those two. And that is a test that looks at the rate at which the signals from the nerves travel. And then in the second part of that test, or the latter EMG portion, looks at the communication of the nerve and how it relates to the muscle. This is a test that is commonly and definitively indicative of peripheral neuropathy. However, it isn't always able to, give you a specific cause, if you will.
It kind of helps you sort out what are the likely causes for this particular pattern of damage that we're seeing.
Correct.
And what is the experience for the patient of having one of these tests, Dan?
Well, we always tell them it's not a happy test, right? Because as Cristina pointed out, the first part involves some electrical shocks actually into the nerves to see how they're conducting electrical impulses. And the second part of the test involves putting a needle electrode into the muscles and analyzing the electrical activity of the muscle. I would like to build on what she was saying in another way too, and I think Tyler's going to jump in too and say that interestingly, an EMG study could be normal and a person could still be having a lot of pain because the very tiniest nerve endings actually are the ones that create pain sensations. And those typically cannot be detected on the electrical test. There have been some advances, and I think Tyler has some experience in doing skin biopsies actually, where you can look at the very tiniest nerve endings. It's become very popular to use this word small fiber neuropathy, meaning that they're so small that we can't necessarily see them electrically and actually a person's, even their bedside exam can look pretty normal. However, they can still have terrible pain. Tyler, did you want to add onto that?
So I'm very lucky as a pain specialist because my colleagues are able to get a lot of diagnoses, and sometimes patients do come with pain with a lot of tests that are normal, blood tests, EMG, nerve conduction studies. And I've been able to offer that in my clinic where we do a small punch biopsy, similar to if you have a cancerous growth that needs to be taken off. Basically, we do 2 predetermined sites, and then we send it to a national laboratory, and they're able to literally use the microscope, stain the slide, and see if there are decrease in the amount of small fibers that are present. That
so actual loss of the fibers they're actually missing.
Yeah, so in other words, something is present in the body that's actually decreasing how many fibers there are, and that's thought to be a very painful condition. So it's nice to be able to give patients at least an answer, even if there's not a really good treatment in some cases.
Yeah, so I think what he's saying really is that it helps to confirm. It isn't absolutely necessary in all cases, but it can help to confirm. And as far as treatment, I think he's going to talk a lot more, and we're going to all talk a lot more about how to treat the symptoms. But what he's saying is it doesn't necessarily identify a disorder that can be reversed, right, or specifically treated. However, the symptoms, like the pain that patients have, can almost certainly be treated to some extent. So in our diagnostic world, we do the electrical tests, we might do a series of blood tests, and we're really trying hard to find those disorders which maybe do have a specific treatment, right? So we've talked about diabetes. A lot of patients don't realize that they're pre-diabetic, right? So I think there's something like, I'll say a number of like 25 million diabetics in America, but then there's like another 80 million pre-diabetics, right? So it's very common that patients show up in the neurology clinic, they've got some neuropathy, and we check and you got a little diabetes, you're pre-diabetic, or you have what they call metabolic syndrome, which is another sort of on the road toward this process of damaging the nerves, basically. And so it turns out that diagnostically we can usually say you've got neuropathy because in about 60-70% of the cases. 30% we say, well, that medical term idiopathic, like God only knows. You've got it, but maybe it's genetic. We're not sure. We're not sure why you have it, but you have it. So the diagnostic approach is pretty straightforward. We do the bedside exam. Maybe we do electrodiagnostics. Probably do some blood tests. It's usually pretty straightforward. And then if we see something an unusual neuropathy that doesn't really fit a clear pattern that we're used to seeing, then we have to dive into some more exotic, special blood tests. Sometimes we look at spinal fluid. We do look at biomarkers, special markers of a specific disease process, maybe some hereditary things. So it can get very involved.
Very complicated.
And there is even a subset of neurology that just specializes in just nerve disorders. And sometimes we reach out to these super specialists to help us sort out something that's more unusual. But the goal is to find something that maybe we can reverse, maybe we can treat that.
Maybe we can stop the progression.
For sure. At the very least, we want to treat their symptoms. Now, one thing that's important, and we've talked about how common diabetes is, that when we hear, okay, you've got diabetes, okay, I think your neuropathy is from diabetes. However, patients can have other things, right? So we always have to be careful. So even if a person has diabetes, it's important to talk to your doctor about it, because they might investigate and find out, oh, you've got something else. I mean, you've got B12 deficiency.
Because you've been on metformin for your...
That's a drug that can cause B12 deficiency.
And is used to treat your diabetes.
Or maybe you've had chemotherapy. Maybe you've drinking too much alcohol. Maybe you're malnourished in some way. And so it's always important to not blame everything on diabetes. I know diabetes gets a lot of attention, and it should, but there can be other causes.
Other causes that we don't want to forget.
Exactly.
The most common place people will experience peripheral neuropathy or neuropathic pain is in the feet. Symptoms of neuropathic pain can include burning, pins and needles, uncomfortable sensations, and more. But why does peripheral neuropathic pain occur, and what can people do about it? Prairie Doc reporter Sam Schauer spoke with Dr. Ryland Johnson to find out more.
Dr. Ryland Johnson is a foot and ankle specialist from Monument Health in Rapid City who helps diagnose conditions like peripheral neuropathy.
Footwear and diet is one of the first things to check to see if improvement is happening.
If your nerves are very hypersensitive, hyperesthetic, which means, sometimes patients with nerve pain like that don't like even light touch just because their feet are just very, very, very sensitive. Perhaps changes in activity and sugar may accommodate reducing how much load.
Dr. Johnson says pain is the number one symptom that should warrant a trip to the doctor, but feeling nothing also warrants one too.
If that pain stimulus is not there and you have a void of sensation or even void of pain, that's when bad things can happen. You can develop a wound in your foot. You can create an injury, or an injury can happen that you're unaware of. And that's how diabetic wounds start and even progress, is because the patients are unaware of the problem and unaware of the severity. We tend to equate the severity of a situation by something hurting. If it doesn't hurt, it must be okay. That's not the case in the diabetic peripheral neuropathy, diabetic patient population that it develops wounds.
So Ty, we're just talking about feet and why feet are so important in neuropathic peripheral neuropathy, be it pain or numbness or whatever. Why is that?
Feet are literally our transport, and when you have altered sensation and pain, you typically do less, and that typically makes the problem worse. I use an acronym with my patients in the clinic, and I say that they're SAD because it affects their sleep. A lot of times they have anxiety about not being able to do things, and then when you can't do things that you really want to do, you're depressed. So a lot of my patients experience those three things with terrible nerve pain in their feet.
And why are the feet so vulnerable? I think we have a graphic here that kind of shows the pattern of...
So on the graphic here, this is from a recent study which led to an FDA approval of a new technology that we use. But basically, it surveys over 200 patients to see where they feel burning pain. And if you see on the left side, you can see the top of the leg, and on the right side, the bottom of the leg. And most of that burning pain is felt at the furthest part of your body away. That's typically the nerves that are affected earliest because they have the least blood flow and the least repair and the least tolerance for any sort of injury. So typically patients feel the pain and the burning at the toes, and then eventually, if left untreated, can start to creep up the leg.
Okay. So when should somebody come in? When should they come and see their primary doctor to get started on figuring things out? Matt?
So sooner the better, right? So as soon as a patient experiences whatever symptoms they might have, as you pointed out, sometimes it's a negative symptom, like they lose feeling or they're losing balance. And sometimes it's positive in the sense of irritation, burning, pain that brings them to the doctor. But as we learned, most of these neuropathies start in the feet. And it's important to see your doctor as soon as possible because, in a way, pain is protective too, right? So if you have a numb foot and you're not feeling that a sore is developing, a blister or something, an injury of some sort. We certainly hear stories all the time. Patients say, oh, I didn't realize I had an ulcer on my foot, or I didn't realize that I stepped in a splinter or something, and they just didn't feel it, right? So it's really important that they start that foot care early on, that they inspect their feet routinely, make sure they don't have any sores there and that sort of thing. But their doctor, their family doctor, can easily start the process of figuring out, well, why do you have neuropathy and what should we do about it? And then they can bring in other specialists if needed. And there's a number of adaptive things that might come into play. We talked about balance and sensation. I don't know, Cristina, if you wanted to talk about some
Dr.
of the
Sanders, this is exactly your field. Tell us about those things we can do.
I'm excited. You know, I would tell patients to come in yesterday, because honestly, when you start to have an alteration of sensation, you know, within your everyday and in your lifetime, it can be, like Ty said, very psychologically altering to just be constantly aware of something being different, waiting for that pain sensation to come on, waiting for it to leave. It can be incredibly distracting, and your fingertips and your feet are really kind of your entrance into the world. And I would encourage patients to see their family providers and even specialists as part of their extended family, and to come in and say, I want you to know that I'm experiencing this, and really glean that detailed history so that we can assist you with improving your quality of life.
And what kinds of things might we do to help somebody improve their quality of life?
Absolutely. So there are many different, what we call modalities or avenues of treatment that we can start with. And one of them that is very successful in intervention is physical therapy, which involves kind of a practice and stabilized training of gait or balance deficits in the event that you experience an alteration or something is different from how you traditionally do it.
So a lot of patients, my patients, yeah, that's great, doc, but it hurts. What do I do?
Yep.
What do I do about the hurt?
And there are many different nerves that come through the body besides pain nerves. And so we can use different types of treatment that address those nerves, which include light touch, palpation, even more of a deep pressure system to move that stimulus or that sensation away from those pain nerves. So a TENS unit, which we kind of talked about previously in terms of conduction studies and EMG, using an electrical distraction to alleviate discomfort. We can look at different types of what we call in the medical community orthosis, which include braces, sometimes arch supports to support the foot, and also to improve walking and mobility. You can look at different canes, balance devices, walkers, so that you maintain your safety and your stability as you recover. And as physicians, we are looking for those causes. We don't want you as doctors to stop living when you experience an alteration in your life, and we'd like to assist you with that mobility, because that mobility can also treat that discomfort.
Yeah, I think Cristina is really addressing the key point of looking at the patient holistically, like have the patient be empowered to do some things on their own, right? To make sure that they have some safety strategies in the home, that they use night lights, because you know, the vision is very critical. When you start losing feeling in your feet, you really depend more on your vision, right? So patients will often describe how they want to, more prone to falling in dim light or darkness and that sort of thing. So she talked a lot about the adaptive strategies that patients can benefit from. And as far as the pain management, which is of course what often leads to the provider, thankfully there are some medications that are often used and they work pretty well. But we have to give realistic expectations to patients and tell them, well, yeah, the medications will probably help you, but they're not going to fix everything probably either, right? So you're probably still going to have some discomfort, some pain, but the medicines will often reduce that to the point where they're functioning better. There's always a trade-off because any medication can have potential side effects too that could be a problem, right? So we have to counsel patients about, yes, it's probably going to help you. It's not going to fix everything. Watch out for these side effects. But thankfully, there are a handful of medications, and basically all of primary care providers and neurologists and pain specialists, they all know, based on scientific evidence, that there are certain prescription medications that work pretty well for many patients. You've heard some names mentioned, and we can go into specific names, but we'll just say that there's a variety of medicines and sometimes combination of medicines. And it never hurts also to look at some of the topical things that can be applied. Those are just over the counter, actually. Patients often come in, well, I've tried that, or I'm going to try this, right? So capsaicin and lidocaine are some products that are commonly referenced. There's another, for diabetics anyway, this alpha lipoic acid is an over-the-counter that might help some people. It's maybe not very robust, but there are things available that provide some benefit. And then there are lifestyle issues. We talked about sort of the holistic approach.
So there's going to be a lot of things we can talk about. Neuropathy is a non-reversible, usually, degenerative disease that takes away feeling in the hands and feet of patients. It can be uncomfortable and painful to deal with, but certain exercises are one thing that can help combat neuropathy pain. Prairie Doc reporter Sam Schauer visited with a physical therapist about exercises to help neuropathic pain.
Neuropathy pain derives from sensory issues that can occur in worse forms of neuropathy.
A stimulus that is normally not painful might start to be perceived as painful. So things like wearing your shoes and socks, or the bed sheet on your foot, or maybe they even are bothered by walking across grass. There's just an unusual sensation that's not perceived as pleasant because the nerve is misfiring.
Stacy Wetfield is a physical therapist with Avera Health in Sioux Falls that helps patients deal with neuropathic pain through a variety of techniques.
If you're coming to see me because of a pain issue, we might do some tissue techniques and teach you some self-massage activities that you could do to help improve blood flow and just general tissue health. We might do things like electrical stimulation to try to just kind of help change what the nerve is talking about and help reduce pain levels. From the sensory side of things, we might help you work on balance accommodation. So we might practice balance drills.
She also shares exercises that strengthen the muscles where neuropathy is present.
So if you were struggling with your walking, we're going to maybe get on the leg press and do some leg press activities. We're going to do some heel raises. We're going to work on some resistance bands and add some ankle weights and do some just different things to kind of really push their strength limit and really kind of maximize the function that they have going for them.
The knowledge gained through the exercises and drills at physical therapy appointments can be crucial in treating neuropathy.
If we start to see that, hey, maybe we're looking at maybe needing some custom foot orthotics or a brace in the leg, or maybe we need to think about a night splint for their hand, then part of our job is to kind of communicate back with their physician and be like, hey, I don't know if you noticed that they were struggling with these things, or maybe they didn't tell you about these things. What do you think about a referral to the orthotist or to the hand therapist who might be more specialized in some of the more bracing and support options that could even give them more comfort, more safety as they move.
So we were talking just a little bit about medications that might be helpful. So what kinds of medications might we use? Obviously we want to address the underlying cause and do what we can to halt that, reverse that, but just to deal with that pain, to deal with that thing that brings people to us, what kinds of options might we have? Dan?
Well, interestingly, the categories of medications primarily involve drugs that have been called antidepressant medications. Now, we've learned actually that a lot of patients, as Tyler pointed out, a lot of patients get depressed anyway. So actually, it has kind of a dual benefit. On the one hand, it suppresses pain firing, pain responses, but it also can improve mood. So there's a family of antidepressant medications that we often use. And then secondly, interestingly, they're anti-seizure drugs primarily, right? So I sometimes tell patients that it's almost like your nerve is having a seizure. It's having this abnormal electrical activity, and we can suppress that by using drugs that are also used to treat epileptic seizures, interestingly. And so these drugs have modest benefit. Interestingly, though, they measure benefit by if it can drop the pain by 30%, that's considered a victory, right? So what that tells us is the drugs are not perfect, and there are going to be patients who don't respond to those typical, and even trying multiple things or combinations of things. And so we're thankful to have pain specialists like Tyler that can sort of take over once the standard things haven't done the job.
And you've got some really exciting things to offer people to help them with their neuropathy.
I do. Yeah, there are a lot of new technologies that have come out in medicine in general, but in terms of pain management, we found that using level 1 evidence with really well-designed studies.
And what does level 1 evidence mean?
Level 1 evidence is the highest evidence that we have in all of medicine. They're typically double-blinded, so the doctor doesn't know which patient's randomized to which treatment.
The patient doesn't know what they're getting.
Correct. Prospective trials, so well-designed going forward. With really well-defined primary endpoints, what the goal of the study is, and then they're followed out for a certain amount of time.
And you have a great graphic showing one of those new treatment options and what difference it makes. Can you explain this graphic to us?
Absolutely. So if you remember the slide that we had from previous, where patients typically feel the burning pain, it's at the farthest end of the extremity. Literally, by using technology to block some of those pain signals at the spinal cord level with a stimulator, you can see on the right side of the study that patients don't feel the burning pain anymore. It's literally a remission of that burning pain. It goes away. So it's really exciting for what I can do to offer patients who don't respond well to medicines, gabapentin, Lyrica, antidepressants. I'm sure a lot of people have heard about gabapentin or Neurontin. They have side effects with them, or their sleep is still affected and they still have terrible burning pain. This is more of a last resort option that can provide sustained and profound relief.
So tell us about this. What does this technique involve?
So the technique is basically placing electrodes in the epidural space, so similar space to where pregnant patients have anesthesia put in so they don't feel the pains of childbirth. But basically what we do is we introduce small wires into the space and tape them to the skin, and the patients go home for a week with a battery that powers these wires to see how much pain it takes away. That's considered a trial period. If they have 60, 70, 80% pain relief, then we can actually put a little pacemaker battery in to power those wires long term. So stimulators have been around since the 1960s, and they were developed for severe nerve pain. Someone has a nerve transected or cut or a crush injury, and it's really developed over the last few decades to encompass a lot of different types of pain. So nerve pain, pain from complex regional pain syndrome, or one of the worst pain states that I see. A lot of neuropathies are treated with that. People have back surgery and they still have pain, or they have nerve damage from back surgery. It literally is the last resort when everything else fails, and it's one of the most gratifying things that I get to offer patients. When it works, it really works.
And how often does it work?
It works. So I have my own statistics, but I feel like my patient selection is on par with the national average. And typically 80% of the patients I offer the therapy to, they have a successful trial, and then they actually can have the implantation of the device. Following those patients out long term, it's about 80 to 90% success rate. So when you think about medicines that block nerve pain, and I know Matt alluded to gabapentin and Lyrica. Lyrica was approved by the FDA with 30% success rate, so 30% pain relief, and it was approved. These stimulators are much higher. there can carry some more risks than taking a pain pill or a medicine to block pain.
Harder to undo.
It's a procedure, but they're a very successful treatment when they work. They're also potentially reversible. So pain specialists basically do everything percutaneously or through the skin with needles, and because of that, the stimulators can easily be removed if there's anything that changes.
What a fantastic and exciting option.
Absolutely.
For people. Wonderful. Haley Nankiville, who was on the show last season, suffered from complex regional pain syndrome. Ahead of receiving a spinal cord stimulator, Haley suffered from neuropathic pain in her foot. On call with the Prairie Doc reporter Sam Schauer visited with Haley to hear her story.
Haley Nankiville, who suffered from complex regional pain syndrome, described the neuropathic pain in her foot as unbearable.
So it basically felt like anything touching my foot, any pressure on my foot felt like it was like crushing my bones, or there's a lot of like the pin and needles feeling anytime anything touched it, to the point where I struggled walking around when it was like super hard for me to put like socks on even in the morning. I slept with my foot in the air because a bed sheet touching it made me want to cry. And
she suffered with this pain for 3 years before getting a spinal cord stimulator in her back.
so my like spinal cord stimulator in my back has now actually taken my pain away completely. And so now I'm actually being able to go back into working out and doing a bunch of the stuff that I used to like doing. One of my favorite things is like going hiking and stuff like that. And so now I'm able to go back to that without any pain at all, going back to kind of the normal feeling in my foot instead of having that pain all the time.
Haley's confidence in the treatment was furthered after a trial stimulator relieved the pain ahead of formal surgery.
Before that surgery, you actually do a trial stimulator. So it's not implanted yet, but the wires are going in. And it healed pretty quick within the first couple days there. And then you have that trial for a week. And so it went away right away. And so then that's how they knew that they could implant it and that it would go away really fast. So, and same thing with the actual surgery, it went away almost immediately.
Now, Haley is feeling amazing and back to normal.
I'm feeling awesome. It's been the best thing. I feel like I'm back to like the normal sense of what everybody feels. Like I have no pain symptoms anymore. I have nothing anymore.
So Ty, obviously she had an incredible outcome there. Why doesn't everybody just get one of these?
That's a really good question. I have a lot of patients who actually come and ask for that right off the bat. Not everybody responds to stimulation. Usually neurostimulation helps with constant, chronic, meaning pain that's been there for at least 6 months. They've tried everything. So Haley had 17 lumbar sympathetic blocks in her back. She'd been on Lyrica for 2 years. She'd literally tried everything else. And part of the decision process was, she was still suffering despite being on all these medicines, was that this is something that we could try, but definitely there was an expectation that it may not work, and that's why we offer the trial. So patients who have severe pain, they should see their pain specialist, assuming that everything else has been ruled out, reversible causes have been identified, or maybe they need, some sort of a surgery to correct their mechanical problem. But stimulation definitely isn't a panacea. It's not a miracle for everybody, like it was for Haley.
Are there other procedures that people might have an option for? People maybe don't want this procedure, or?
Absolutely. So a lot of patients, they have a weird feeling about something being put inside their body, understandably. Because of that, we have other treatments, nerve blocks, shutting off a part of the nervous system that regulates severe pain fibers and blood flow. Sometimes that leads to months of relief. We're also able to target peripheral nerves, specific nerves that are damaged. let's say with a surgery or with an injury, and we can place a small wire directly on that nerve instead of higher up in the back, close to the spinal cord. So there are lots of other options. And by far, as a pain specialist, I prescribe physical therapy more than I prescribe any medicine and any technological advancement. So we talked a little bit about medicines, and I really like topical medicines because patients are forced to rub that into their extremity, and a lot of times when their pain is so bad, they don't want to touch their extremity. And that's when they can develop the worst types of pain, like complex regional pain, or have a symptom called allodynia, where even a feather brushing against their leg hurts. And that's where Haley was in her pain journey.
So again, an emphasis on why it's important to take action early.
Correct.
To not wait until the pain is intolerable before we try to do something about it.
Correct.
So, all right, last few minutes, what do you want, Dr. Simmons, people to go home with, our viewers to remember?
Sure. So to build on what we've all been talking about, if you have symptoms, go in, get checked, get an evaluation completed to figure out to the best of our ability what's causing it, what can be done about it, because almost certainly we can do something to help the patient. So go in early and get a diagnosis and get a treatment plan.
Dr. Sanders, what are your take-home messages?
I would really like your listeners and others out there who are experiencing any form of pain to really consider their doctor as a counselor and a friend, and really encourage them to go and seek treatment options, or even just have a discussion surrounding pain. Physicians are really here to advise, and a lot of training and a lot of loan debt helps us do that. So please come in and please let us talk with you about what you're experiencing so that we can create a plan together, either in a doctor-patient relationship or maybe different specialties to help improve your quality of life, to help you get back to your living irregardless of your pain. We may not, as physicians, be able to eliminate it, but we may have some pretty good ideas that we can share with you to form a plan to get you back to doing the things that you love and enjoy doing.
We had been having a conversation off camera here, and you had what I thought was just a really beautiful point about the impact that living with pain has on the individual. Could you repeat that for our viewers? Or
Sure. I was just kind of explaining that my opinion in terms of pain is that it's very multidimensional. It affects all areas of life, and there's a point where people do not know how to assist someone who's in pain, and that can make that person feel very alone and isolated and feel like there is no end to their suffering, so to speak, and really affect their viewpoint, and also things that they may try to alleviate the pain. And I just want people to know that that can not be the case, that there are things that we can do not only to help directly with that cause and effect from the pain, but many modalities to implement that would help people be successful on their pain journey.
pain can be very isolating. Mm-hmm. You can feel very alone. And people don't always have a lot of sympathy if they can't see the problem.
Correct.
So that nerve pain is invisible, and but it's real. It's
mm-hmm.
very real.
Absolutely.
And we all need to remember that that person is really suffering, even though you can't see that. So mm-hmm. that's my take-home message. Ty, your take-home message.
My take-home message is that we have a lot of amazing medicines, a lot of amazing doctors, a lot of amazing physical therapists and new technology to help patients, but really it's to get back to the basics. So moving, walking, eating healthy foods, doing the things that we know we should be doing from the beginning, and you won't have to see us. You won't have to, go down that road.
Hopefully.
Hopefully, yeah.
You'll greatly reduce your chances.
Exactly, but good food, good socialization, lots of activity, walking. That's my takeaway.
In fairness, though, we are super fun.
Absolutely.
So if you try those things and they don't work, like, please
may want to come
visit.
and see us and see what we have to offer. So anybody else, any last minute thoughts, anything somebody said that brought something up?
No, a great wrap-up, I think, is the idea of holistic wellness, really, to look at the whole person and their lifestyle and how they can help themselves. It's not just about what we can do for people as much as what they can do for themselves. It's really a partnership, and I think we've heard that message from our guests today, and I would just emphasize that.
Yeah, that those lifestyle things are really important, that you are empowered. Yeah. You are not dependent on us to fix things. There are things that you can do to fix yourself.
And don't give up. You know, don't think that this is something that you will have to live with the way that it is currently. Sometimes when someone with pain comes to see me, and I assume one of you might be doctor number 10, and they're on procedure number 5, and they've tried a lot of the things that are more interventional, and that doesn't mean that you're stuck with your pain identity. You know, there's a person in there that we need to find.
Yeah.
Absolutely. And thinking about your explanation that a lot of these procedures are new in the last 5 years, maybe we've done what we can for now, but there may be something else down the road. In 5 minutes.
A lot of hope for the future, for sure.
A lot of hope for the future. So, and talking about your experience as a neurologist and how that has changed so much in those years. So everybody, there's hope. We'll be back after this.
Miss an episode or looking for a specific topic? Head to our YouTube channel or website, prairiedoc.org, today to access all on-call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB and Facebook for new shows.
And my house, classic TV is a given. My 93-year-old father-in-law enjoys watching reruns of Westerns, Perry Mason, Andy Griffith, Gomer Pyle. With these old favorites come commercials targeting an aging population, Medicare Advantage plans, reverse mortgages, and miracle solutions for neuropathy, with free consultations for the first 250 people who call. Every time we see one of these neuropathy advertisements, my father-in-law looks at me hopefully. His neuropathic foot pain has been intractable for decades. All the usual medical solutions have either brought minimal relief or intolerable side effects. It interferes with his sleep, and the shuffling of his feet in response to the pain literally wore holes in the dining room linoleum. Any situation without a clear solution leaves an opportunity for the unscrupulous to pounce. As I watch those TV ads, I wonder how many people send in their money or otherwise fall victim to medical quackery. Years ago, I accompanied a friend to a hair loss consultation. He was awed by the trappings: white coat, scientific sounding terms, glossy pamphlets, and patient testimonials. I was less impressed. What was in their product? They couldn't tell me. It was secret. Where were their studies? They pointed to those patient testimonials. Did they have any published data? It wasn't available yet. I was struck by the scientific babble, too. It sounded impressive, but it didn't make any sense to me. Today, similar organizations offer invitation-only dinners at local establishments, followed by the opportunity to sign up for treatment that may cost you out of pocket because insurance won't cover it. They have professional-looking websites with quotes, supposedly from delighted customers, and perhaps a few references to publications doctors might call throwaway journals, or to decades-old articles, or research that doesn't actually involve the treatment at hand. There might be claims that the treatment is ancient or brand new, or that they, usually doctors, the government, or big pharma, don't want you to know about it. Legitimate medical treatments are not kept secret. They are presented to other professionals for critique, evaluation, and replication. Researchers try to determine if a treatment might be effective only in certain situations or more broadly. If it is promising, it becomes widely available, and insurance coverage often follows. Sadly, neuropathy, like many chronic pain conditions, has a variety of causes and a variety of often less than satisfactory treatments. It is an easy target for snake oil salesmen. As always, talk to your doctor before you try something that sounds too good to be true. Thank you to our guests, Dr. Sanders, Ptacek, and Simmons, for volunteering their time to help us learn more about neuropathic pain. If you would like to see and hear more episodes of this program, please like and follow us on Facebook or YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper or online, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. So, from all of us here at On Call with the Prairie Doc, thank you for joining us for another episode of health information based on science and built on trust. Until next time, stay healthy out there, people.
Whatever type of loss you've suffered, there's no right or wrong way to grieve. But by understanding the stages and types of grief, you can find healthier ways to cope. Coping with grief and loss, the importance of taking time to heal. Next time on Call with the Prairie Doc.
Mom, can you believe we are already entering the 21st season of On Call with the Prairie Doc?
It's amazing. Last year was so fun celebrating our 20th season. It was great to see the old shows and to just highlight the honest science and trust that our program is built on and that Dad started so long ago.
Yeah, and to see how it's grown. You know, to see it's not just a television program that you can find on Thursday nights at 7 o'clock, but it's something that you can check out on one of your favorite podcast networks or YouTube. Share these videos to your friends and family on Facebook.
There's a lot of ways that Prairie Doc is making an impact. We know it wouldn't be possible if it wasn't for you, our viewers, and for our corporate sponsors and our private sponsors. We are completely privately funded foundation, so your contributions make a difference. And did you know that a couple of years ago, the South Dakota Department of Health asked us to do some special programming that they felt was important for the whole state to know. We felt really honored that they would ask us to be a part of that. So you donors, you helped in providing good education for the state.
You know, as a nurse, one of my primary responsibilities is to advocate for my patients. And this program really allows our prairie docs, as well as the volunteer doctors, to advocate for public health across our state and into the surrounding states as well, which makes it particularly nice when a patient will come up to me and tell me that they really enjoy the program, or my parents watch your show every week.
Yeah, I hear that a lot, and it really is humbling and gratifying.
Yeah, and I'm excited and humbled to be joining the Healing Words Foundation board as we work to make an impact on the lives of our supporters and to further that mission.
If you would like to help us with this important work, we hope that you'll talk to your friends, you'll share our program on your social media page.
And if you want to make a financial gift, please give directly at prairiedoc.org or mail your gift to the P.O. Box 752, Brookings, South Dakota 57006.
Thank you for your support.
All right, Mom. You ready to go for a little walk?
You bet.
Let's get those steps.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
and with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Vance Thompson Vision, Monument Health, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Yankton District Medical Society, Orthopedic Institute, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swiftell Communications.